major chunk of the things from where you are liable to get questions, you are liable to get in your case scenario. So that's how you should be focusing on the preparation also. It shouldn't happen that you give 90% of your time to malignancies and 10% of your time to CM's commerce. It should happen on the other side. Okay, one thing. And second thing is always remember for the DNB, OSCEs, practicals and the Viva purposes, the main important thing is you should know something about everything, rather the other way around. Okay, you should know something about everything. It is not practically and humanly feasible that you are remembering everything about everything. So try focusing on the important things first. You cannot afford to miss anything about COM's commerce. Then comes your thyroid case. Then comes your oral cavity, that is tongue, and fourth will be your larynx. Okay, so let's start with today's class. This will be a mixture of both of the things. That is the questions which will be asked, which can be asked in your practical exam, and second thing will be the apart from the question asked, the OSCEs which are concerned with this thing, that also I have included along with it. This will not be a regular Viva based class. You will understand in a moment. Just a minute. Someone else is there to join. So let's start. Okay, guys. So sorry for the delay. See, coming to the theory part as it was concerned, two things. The scheme of examination that consisted of your regular cases, which was around, I think, 18 to 20 sets of questions were there. From there, that you can start. Okay, and the examination scheme will be same as you will use for your CA larynx. Thing will be the main difference thing will be HOBA. Today we will be focusing more on the questions part, right? So so and so year old patient came with complaints of non-healing ulcer. This is one terminology you can use, or you can use the plainly you can use growth. Okay, on whatever side which is available, that is right lateral border of the tongue, left lateral border of the tongue, tip of the tongue, dorsum of the tongue. That's all you can use. Since so much duration. One. Second is your progression. Okay. Progression may you will have to comment upon the size. That initially the growth was 1 into 1 centimeter in size, which has progressed to the present size of 3 into 2 centimeter, or whatever size you can appreciate. Third thing is what are the associated features associated with this growth? Is there any pain with it, bleeding with it? Okay. Then two things apart from that: dysphagia, odynophagia, 2, dysphonia, 3. Then is there any history of cough associated with it? What does this signify? Aspiration. Like if the patient is having aspiration, he'll have this history of cough and all. Okay. All these things have to be included. Any history of hemoptysis to rule out the other things. Okay. Past mein, you have to comment upon the any previous history associated with this disease. That was he or somebody having this kind of disease previously. One. Personal mein again, smoking and alcohol will come into play. Why it will come into play? We'll see just 2-3 slides downwards. All the questions have included here only. Fourth, family. Any history of familial cancers you have to include. Here only you'll be asked about again repetition of the same question. That what are the familial cancers that you know about. So you should be ready with 2-3 syndromes: Bloom syndrome, Fanconi's anemia, ataxia telangiectasia, है ना, xeroderma pigmentosa. We discussed it last time. Again, keep on revising. Personal हो गया, family हो गया, and any treatment which you have taken, that you have to include. After this will be coming, the examiner might ask us to either summarize our case, one, or be ready with the diagnosis part. So you might ask us to summarize the part or be ready with the diagnosis. So that's I always advise that as soon as you have been allotted your case, you know that I have 20 minutes. I have 20 minutes for this case. So within those 20 minutes, you have to complete all your theory part. You have to complete all your examination part, and after completion of all these things, you have to make this thing in your mind. You have to write it on. If you have a piece of paper, write it on it. Other hand, memorize it, practice it 1 or 2 times before you utter the same things in front of the examiner. It's always better that you practice it once or twice before going in front of the examiner, because it makes a very good impression. Like, in the first go, you utter the entire diagnosis without hesitation, without any hindrances. Okay, so you have to, how the diagnosis will go, that this much over year old, male, female, resident of so and so, is a case of ulcerative growth, right lateral border of tongue, or whatever location you want to say, and probably malignant. And here you have to speak about the staging. Okay. So what 2 impressions will it make? One thing is, as soon as you say probably malignant, so they will ask you what are the, one question will come is, what are the DDs of tongue growth, mass over the tongue? 1, why do you say it's malignant? 2, and 3 is, as soon as you utter your staging, so they'll ask you what is the T staging, N staging, M staging, whatever they want to ask over here. This thing, diagnosis and summary, it varies from center to center. So this is generally what we were taught, and it changes from, it's a sort of info that keeps on changing from places to places. So if you have something different which has been taught to at your places or at your institution, stick with it. Okay. So now coming with the questions that are associated with this thing. Data I have used from, one is Codron, second is your Stell, and 3 the OCNE PubMed lectures which we have on net. So from there I have used, mainly from Stell and Scott. Okay, so from here 3-4 things whose questions were pending from the last test also. Okay, so this was the first thing, that why alcohol and smoking causes this malignancy. So one word we had discussed last time, that was synergistic, and these are around 6-7 points, so you have to remember everything. One is that it acts as a solvent when you take along with smoking. 2, it has its metabolites such as acetaldehyde, which itself is toxic. Third will be your it acts on the DNA repair activity. 3, immunity decreases. 4, and apart from that, vitamin deficiencies, etc. and etc. Around 5 to 6 points are there why alcohol and smoking goes hand in hand. So one thing you have to remember over here. Second thing is this thing. This has been a very common Viva question, that if a patient has quit smoking for say 10 years, 15 years, 20 years, does he still have the same risk of developing the malignancy as he would have if he had not left the smoking? So you have to answer this way, that the risk of oral cavity is reduced by 30% in those who have discontinued for about 9 years, and 50% for those who have discontinued for more than 9 years. So everything which you speak, that has to be backed up by some scientific data, and there's nothing better than quoting something from Scott Brown. Okay, so please remember this thing. This 4 lines, please remember. You shouldn't forget about it. Now coming ahead over here, see, these are again your familial cancers, which you should remember about it. Lee-Fromani syndrome, Fanconi's anemia, Bloom syndrome, ataxia, telangiectasia. These 4 or 5 at least you should remember and speak in one go. Okay. Coming to the TNM classification, please ratify it because they have included two things over here. That is your tumor thickness and depth of invasion. That's why this staging has become important after the AJCC 8th edition changes were made. Okay, so we'll just discuss it in an easier way. यहाँ पे we will be discussing tumor in the greatest dimension. Tumor in the greatest dimension, and this will be your depth of invasion. Okay, this itself is another question. What is the difference between tumor invasion, tumor greatest dimension, tumor thickness, and depth of invasion? So this is T1. So the first thing is this should be less than 2 centimeter. यहाँ पे centimeter है, इधर पे millimeter है. One difference is this. Okay. So figure is 2. Here figure is 5. This is centimeter. This is millimeter. Then comes to T2. Again 2. 5 to 10 mm. 2 to 4 less than 10 mm. And when it comes to T3, it becomes more than 4 centimeter and becomes more than 10 mm. This you have to remember. Okay. So as you can see over here, T1 is tumor 2 centimeter or less in greatest dimension and 5 mm or less depth of invasion. Goes for T2. They have like broken it up into two separate paras, and in T3 it's more than 4 centimeter or more than 10 mm of depth of invasion. T4A, B you have to remember separately. One difference which I would like to mention over here is that this extrinsic muscle, this one, can you see T4A? This has been removed in the AJCC 8th edition. So this can be like asked what are the changes in AJCC 8th edition. So this is one of them. Okay. Coming to the second question which is being asked is, what are the pre-malignant lesions of oral cavity? So to break the monotony, can I have somebody who will answer something for me?
So pre-malignant lesions and pre-malignant conditions we can divide.
हाँ बताइए.
Pre-malignant lesions means lichen planus, erythroplakia,
leukoplakia. Anything else?
Sir, it can be divided like high risk, medium risk, and equifocal risk. And high risk leukoplakia, erythroplakia, candidiasis, reverse smoker palate.
हो गया था मैं बैठा हुआ.
And then medium risk it's OSF encephalitis ascites and siderophonic dysphagia. And then equifocal risk it's oral lichen planus, dyskeratosis congenita and DLE.
Good. ठीक है. So your theory is still fresh in your mind, है ना? So and whatever Dr. Irfan you were saying, that's also correct. See, one thing is, again I would like to reiterate, nothing is entirely wrong or right in all scenarios. Okay, it's how you present in the exam. So now theory part is over. I'll not be discussing about the theory things. In practical, what they will ask is, these three are the most common thing: leukoplakia, erythroplakia, and the OMSF. Okay, agreed with me? These are the three most common things. So one question which they ask generally is, what is the transformation ratio of malignant things? Like a person is having leukoplakia. So what are the chances? What are the percentage that this lesion will develop into malignancy? So that is the question over here. So I'll answer it for you. Leukoplakia, this is 1 से लेकर 2.9%. Data is from Scott Brown. Erythroplakia, it is 13 to 50%. Not from Scott Brown, from articles I'll share on it. OMSF, I was not able to find any transformation ratio or percentage which could be clinically associated with it. Okay, but these two things, please remember, leukoplakia mein it's up to 2.9%, erythroplakia till 50%, 13 to 50%. Okay, now coming to this thing, two more questions which just associated. Reverse smoking. Which malignancy is associated with reverse smoking? कौन बताएगा?
Palate.
ठीक है, good. Second will be with pipe.
Lip cancer.
Lip cancer. ठीक है. And whenever you say lip cancer, whenever you have free time, when your mind is free from all distractions, lip के लिए आपका जो flap surgeries है, around 4 or 5 named flaps are there in the lip surgeries. So revise that. Okay, we'll be sharing it, but this is one of the question which is very confusing. and difficult to understand. So this you have to go ahead on the lip, like carapanctic flap, burrow flap. 2-3 named flaps are there apart from this. Okay. So again, coming to this thing, see, this is given in Scott bone, I think 2-3 times. Okay. So please remember it. Inherited cancer syndromes, इसमें Lynch syndrome दिया है, Bloom syndrome दिया है, Xeroderma pigmentosa is given, Lee-Fromeni syndrome, ataxia telangiectasia. Okay, so please go through it again and again, again and again. Okay. Now one more very important question is there. What is Slaughter's hypothesis? Somebody else will again break the monotony.
Field cancerization.
Field cancerization. इसी में लिखा हुआ है. ठीक है. Again highlighted. ठीक है. So what I found it ना, like when we were doing residency, that time Scott Brown used to be one of the very boring books, like how to study, why to study type of things. And when like after completion you study na, you read over it, so you find it like NCRT. Like we used to prepare for our AI NEET UG days, right? So उसमें NCRT में like from every line there's a separate question which is being asked. So this is like turning out to be new NCRT. Okay. Now second question is, what are the 5 S of cancer? ठीक है. So please read over here only. ठीक है. It's smoking, spirits, syphilis, spices, and sharp teeth. ठीक है. There might be plus minus 1 or 2 extra depending upon what places you are doing your teaching. Depends upon the professor who are teaching you. So don't forget this. What are the 5 S of your oral cancer? ठीक है. Third question. What is Carney's complex? Please go through it. ठीक है. Associated over here. Now, what is this? Okay. See, this is your PubMed articles which I could find. This is more important for your theory because there are 2 flowcharts over here that people preparing for theory should go through it. Okay, you have to produce it in a flowchart format if you want to get good marks. And for people who are going to give exam next month, please see 2-3 things over here. What do you think? Yeah. So they'll ask you, hey, doctor, what are the pathways of cancer? Why does cigarette smoking causes cancer? Okay, so you can answer it easily from this place. Okay, that the exposure to carcinogen, the formation of the covalent bond between the carcinogens and DNA, 2, and resultant accumulation of permanent somatic mutations in the critical genes, 2. And this second question which can be asked is, what are the carcinogens in smoke which causes cancer? ठीक है, वो it comes in TV that it contains this many amounts of इतना carcinogen होता है, and apart from nicotine we don't remember anything else. Okay, so you have to remember certain amount of number. One is your polycyclic aromatic hydrocarbons, nitrosamines, aromatic amines, aldehydes, organic hydrocarbons, metals, और इसके अलावा nicotine जो है वो तो है. ठीक है, 2 हो गया. Third question ये वाला flow chart. ठीक है, how it causes cancer. How cigarette smoking causes cancer. This is a flow chart. Please go through it. If you have some data with yourself, revise it, learn it. Otherwise, go through it. Okay? And again, same thing has been repeated over here again. What are the carcinogens in cigarette smoke? They have asked it multiple amount of times as soon as you will utter in the person smoking. So these are the pack years. They'll ask you how did you calculate the pack years. Then how does cigarette smoke causes cancer too? And what are the carcinogens present in cigarettes? Okay. So these are the things that you should be aware about it. Okay. So let's move ahead. Etiology of C oral cavity. Okay. This is apart from being a long answer question for your theory. People preparing for your theory, this is a very favorite question because everything can be broken into different viva questions. So first etiology goes tobacco. So tobacco ke 3 questions we discussed just now. Coming second to alcohol. Okay. Alcohol. These are the 5 points taken from your Scott Brown, which we saw. Okay. That it acts as a solvent. This is the toxic compound over here, decreases DNA repair, decreases immunity. Please remember, this is important. Third thing will be your infection. What infections can cause your oral cavity? 3. Mutation factor, you can all answer. Dental factor, please remember. Sharp tooth. Okay, how this can be asked as a question? Like I remember in my final year days, we had a case in which a 32-year-old lady, she was having this CA tongue. She was operated, blah, blah, blah. So the first question I was asked is, what is the etiology of, how did you say that inko cancer kaise hua? So like routine, I said tobacco, smoking. So like he countered me that, do you think this lady smokes or takes alcohol? I said no. So what is the etiology in this patient? So generally in this patient, if these type of patients when smoking and alcohol is not present, you have to look for this sharp tooth. Write in some good handwriting. Okay, so always in your patients, do look for this sharp tooth. Some genetic and immunological predisposition, we read about it. Carney's complex, we saw. Again, coming to this thing, ECOG. ECOG full form, please revise. Eastern Cooperative Oncology Group. This is 0, 1, 2, 3, 4 and 5. Okay, so they'll ask you ki, Dr. Saab, why did you ask ECOG? Like just a general condition, may we start with general condition of the patient. You have to mention either ECOG or Karnofsky. Anything, whatever you remember, whatever is followed in your institution, remember that. Along with the scoring, you should use it. 1. Number 2, full form of ECOG, Eastern Cooperative Oncology Group. This is the important thing, can be asked. Now, idhar pe hi, I have attached this. I don't know why it's not very clear. This is Karnofsky performance scale. This is for 0 to 100. Okay, this thing. 0 to 100 hai. This is 0 to 5. This you should remember. ECOG pura yaad rakhna hai, 0 to 5. And they'll ask, why do you ask for ECOG? So you have to answer like it's a performance scale basically. And we'll be able to decide how the things go for our patient, how the treatment performance is there in the patient. 2, third is like for the treatment, the patient will undergo surgery, chemotherapy, radiotherapy. So how after that his performance scale changes. Okay, so you have to answer accordingly. Don't forget it, it's an important part. Now, coming to these things, nerve supply of tongue. One question, second question is your muscles of tongue. Okay, this is important from your anatomy section. This will be helpful in the when we'll be discussing about the surgical questions over here. So what are the when they ask you about muscles of the tongue, you have to divide it into 2 parts. Intrinsic, आसान है, extrinsic, ठीक है, and in extrinsic, genioglossus, hyoglossus, styloglossus, palatoglossus. ठीक है, इसके नाम में पलट है. Palat means something different. Okay, so all other are supplied by hypoglossal nerve. Palat, something different, is by vagus nerve. Okay, and all of you, if somebody having any confusion or any problem remembering the names of these 4 muscles, can I have a hands up if somebody is having any problem in remembering the name of these 4 muscles of the tongue? No?
No, sir.
Sure, lovely. Please remember it. It's very important. Coming over here. See, this was the thing which we started in the first thing. Leukoplakia has conversion rate of around 1 to 2.9%. They have mentioned specifically floor of mouth over here. It's a subsite of the oral cavity itself. Okay, other than this, there is no data apart from this given in your Scott. Okay, second question is, this is important things I have marked it before you. This thing, that the lymphatic drainage of your lateral border of the tongue. Read this paragraph, okay? There's a marker. This thing. Okay, so it's to the ipsilateral cervical node, and drainage of your midline tip base of tongue occurs bilaterally. Okay, so this will occur. This you have to answer when you'll be speaking about neck dissection. He'll ask you, Dr. Sir, you want to do neck dissection of which side? So you have to be in confidence with this paragraph before saying, sir, bilateral or unilateral. Okay, chalo, moving ahead. One thing is there. Second is your this is not an important thing. Okay. Chalo, here around 3-4 questions are there. The first thing is, what do you mean by compartmental approach? This can be a OSCE question. Okay, what is the compartmental approach? Okay, so over here you have to answer this thing. That हाँ बोलो.
सर जैसे वो कंपार्टमेंट डाइसेक्शन ऑफ इंट्राटेम्पोरल फोसा वैसा करके कुछ होता है क्या?
It's almost on the similar guidelines. ठीक है, almost on the similar guidelines. So what they are saying over here is that the aim of doing this surgery, by this approach is that you have to retain maximum amount of tissue. That's it should be functional. And over here, preservation of the tip and base of the tongue is more important. two things. And apart from this is the second thing where you will use monopolar cautery and कहाँ पे coagulation है, कहाँ पे आपका cutting tissue आएगा, ये वाला है, ठीक है. That use of monopolar cutting through the mucosa will be changing to coagulation when you will be reaching the muscles of the tongue. So this you have to just remember if you want to answer it, otherwise you can skip it also. 2. Number 3 question will come is what are the like flaps आप कौन कौन से लेंगे. So this is over here. Abhi in the later half we'll be discussing that depending upon the size of the depending upon the dissection, whether it's hemiglossectomy, glossectomy, what kinds of flap we'll be using. For name part, name concern we can read over here is this is your radial free forearm flap and ALT. These are the two names which you have to remember over here. 2 and 3. This thing. This will remain a very, very, very important theory question for at least for the next 10-20 years. Management of N0 neck in CA oral cavity. ठीक है, this has been a very important long answer question. This अगर आपको CA tongue आता है तो this question will definitely be asked. How will you manage neck? Whether you will do neck dissection or not. Okay, so importance of this you will realize by the end of this class. Why I was saying this thing. Okay, coming ahead. ठीक है, full form of port that you have to remember. ठीक है, this is post operative radiotherapy. Second thing is indication of port. Port in CA tongue. First question. Second, indication. So you have to see reading it as a theory chapter 10 pages in a while is always boring, and we tend to miss on the important point which you have to remember. So when you are specifically reading about ports, you have to remember two things. What's the full form? Post-operative radiotherapy. One. Second, when you will do port, so break down करके लिखा हुआ. When the margins are positive. 1, 2 is multiple cervical nodes. 3 is extra capsular spread in the neck and stage 3 or 4 disease. Apart from that, perineural spread and thickness more than 9 to 10 mm. So these are the 5 points after which your radiotherapy, why when you will advocate radiotherapy. Like अभी ये कैसे पूछा जा सकता है वाइवा में, they'll ask you how will you manage the case. So you will say sir I will do a CT scan. तो पहला क्वेश्चन तो यहीं पे फंसेगा, whether you will do a CT scan or a MR scan. Okay, so for lateral border of the tongue, for the buccal mucosa, all these places MR is the treatment of choice because musculature MR is always better. Now the disadvantage of MRI is one thing is the expensive nature, second thing is the availability of MRI is the issue. So generally we tend to answer what you follow in your institution. Like in our institution we used to have only a CT scan for the patient. So I was confident कि भैया हम CT scan ही कराएंगे, ठीक है. So with the CT scan what you will look, sorry, whether the tumor has crossed midline or not, whether the spread is there in the lymph nodes or not, all these things you will assess. Then what surgery you will decide, sir I will go for wide local excision with bilateral neck dissection. Two things. Now after neck dissection the viva will go on neck dissection. Third thing, sir, after that anything would you would like to do, sir I would like to give radiotherapy also to the patient. Now as soon as you say this term that I would like to give radiotherapy to the patient of CA tongue operated, he will ask you bhaiya what is the indication, when will you give and when will you not give. So these are the 5 points you have to answer. Tak 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 tak. So these are the indication. इसको I suggest you write it down on a piece of paper. In neck dissection का ये है indication, radiotherapy का ये है 4 indication. So that's a important way and that's how you will remember it. You will read it today, definitely you are going to forget it tomorrow. That's a human nature. So either you should keep on revising it or write it somewhere else too. ठीक है, I'll not trouble you much about all these things. हो गया. इसके बाद अगला क्वेश्चन है आपका, ये फिर से it's coming it again. ठीक है, slaughter et al. Spelling एक बार देख लेना, I might be wrong in spelling. Slaughter et al. He gave this concept of field cancerization. Again and again it's coming in some way or the other. Please revise it. Malignancy will not be complete, will be incomplete without this discussion, है ना? So because of the exposure, common exposure of the carcinogen, the whole aerodigestive tract, the same carcinogen is being exposed. So apart from one cancer which you are discussing, another one can also occur in a certain period of time. Okay, so again coming to the same question, indication of neck dissection in CA tongue. ठीक है, so these are the, जैसे पोर्ट में हमने पढ़ा क्या 5 चीजें थी पोर्ट के लिए, वैसे ही फॉर द नेक डिसेक्शन these things are important. ठीक है, 1, elective neck dissection level 1 to 3 should be dissected. 2. Second thing is bilateral neck dissection should be considered in tumors that extended to or beyond the midline. Now, यहाँ पे I would like to break the monotony. As soon as you hear the word decruise, what comes into your mind?
वो elective versus selective neck dissection in
हाँ बताओ.
मतलब उसमें कि सातों साथ ओटी में ही कर ले या करे ऐसा उन्होंने.
ठीक है. So this should not come into our mind because अभी after this क्या कहते हैं, where have I mentioned it? मेंशन किया है नहीं किया है? आप लोग अपना ना ये जस्ट ओपन योर मोबाइल, ठीक है, उसमें जो ये डिक्रूज एट ऑल का आर्टिकल भेजा हुआ है आप लोगों को. आई हैव सेंट यू एन आर्टिकल ऑन दिस डॉक्टर डिक्रूज एट ऑल, ठीक है. So that is why is it important? I'll just explain it to you in a gist. See, as a resident, we are expected to know many papers, but there are few papers which you shouldn't forget at all. Okay, so decruise et al वाला जो paper है for management of this neck in oral cancer, that's very important. Like for people who are in first year and second year, just have a gist of it. That what used to happen was that CA oral cavity was like people used to, this was I'm talking long back, that people used to surgically remove the malignancy, and like if there was no spread in the lymph nodes, so they did not touch the neck dissection nahi karte the. So what happened? Dr. DeCruz divided patients into two sets. In one set, apart from the treatment of your CA oral cavity part, oral tongue का surgery के साथ, electively they performed the neck dissection. And in the other set of patient, what they did was they kept the patient on follow-up. Surgically, they removed the malignancy from tongue and kept the patient on follow-up by doing routine scans that whether the spread is there in the lymph nodes. So they were surprised to find that the people who were people who were kept on follow-up, the rate of this spread was too much. So this study had to be aborted in between, and like this study was framed that management of neck is very important in oral cavity, whether you are able to see it over there or not. So that is the discussion one. So please go through this paper. It will be very advisable if you remember the data also. Like I'll just give me a minute, please. Yeah. Okay. So as you can see over here, please focus. Okay. DeCruz et al. Basically they had an outcome of around 500 patients. 245 in the elective surgery group and 245 in the therapeutic surgery group. These are the key words that you should utter. As soon as you will say these words, the examiner knows that this guy has read about it. You will definitely clear the passing marks from one question itself. And what they did was that at 3 years, these were the rate of survival in the two separate groups. Okay. So here they decided that patients in the elective surgery group had a higher rate of disease-free survival. So that's why there are only few places where West is looking up to us for literature. So oral cavity ke 500 patients is very difficult to find in West. So these are the places where India is leading the world. Oral cavity ho gaya, JNA ho gaya, mucormycosis ho gaya. So these things we shouldn't forget about it. One. Second thing is, apart from DeCruz, I'll just deviate from the point for one point. CA hypopharynx is very important for us. Why is it important? If you read Scott Brown, CA hypopharynx, Dr. Harikesh Pai sir ka naam hai uspe. Okay, so there are few places where Indian scientists have very much contribution over there. So that's why CA hypopharynx, it becomes important for us. You will definitely keep on getting repeated questions from this section. So please remember this data, okay? ये जो percentage है ना, percentage you should remember. If you can remember. Otherwise, normally भी तुम बोल सकते हो कि indication of neck dissection के लिए DeCruz et al. का paper you can quote. ठीक है? It's a standard paper. Okay. This is you can yeah. So what are indications of radiotherapy? So we are clear with this thing. You can answer 5 points. That these are the indications for PORT. Surgical margins we have already mentioned that 1 centimeter surgical margins, clear margins we are taking it. ठीक है? Okay, चलो आगे चलो. इसमें कुछ है. ठीक है? This is the marginal status. ठीक है? Courtesy from your Scott Brown. चलो. What is Weiser's approach? When you are coming to the management of this thing, so this can be asked with you. What is Weiser approach? ठीक है? What's the meaning of Weiser? I think all of you know what do you mean by Weiser? हाँ जी, कोई बताएगा वाइजर मतलब क्या होता है?
The front part of bike, sir.
Front part of bike. हाँ, exactly, वो जो that portion which prevents excessive air to come inside. Okay, so you should go about this thing. Second comes over here. This is the thing. What are the sites of mandibulotomy? ठीक है, ये साइट्स वाला क्वेश्चन आपको दिस विल कीप ऑन ट्रबलिंग यू इन 3 places. One thing is maxillectomy में what are the sites of cut? One. Second is rhinoplasty में where do you do osteotomy? And third is mandible surgery. What are the places where you will place cut? So mandibulotomy you can see from over here. Maxillectomy I'll share it, which will be divided into like all 3 parts of 3-4 different types of maxillectomy, and rhinoplasty. This I'll share these 2. Okay, so please remember sites of osteotomy in these 3 places. Okay. Other questions? Important types of neck dissection. ठीक है, we will be discussing neck dissection. अभी one more class will be there for this head and neck scenario. In that we'll be discussing about head and neck dissection. One, types of neck dissection we remember. 1, 2, what structures do you remove in each? Please write it down in practice. It's very easy to remember. Okay, you read it, remember, fine. But try answering it to yourself. That what do you remove in R&D? 1, 2, 3. What do you preserve in MR&D? 1, 2, 3. Okay. उसके बाद क्या आता है? So try answering it like supposedly examiner is sitting in front of you across the table. Practice these things. ठीक है? We have been learning these things right from the first year. But believe me, without practicing how to answer, you will definitely fumble. Okay? 3. And third question over here will be your incisions. Now daily we'll start including 1 incision daily, like one day Weber Ferguson incision, second day Moore's incision. ऐसे करके around 7 to 8 incisions are there in your head and neck region. So daily we'll discuss one of them. Okay. So next question will be, as soon as you'll say that certain MR&D will preserve either one of them, IJV, SCM or SAN. So they'll ask you, why do you preserve why do you remove IJV, or why do you preserve IJV? Why do you remove or preserve SCM, or why do you remove or preserve SAN? So coming to this thing, why do you remove IJV? So why do you remove? Because most of the lymph nodes are around the internal vein. So if you remove it, you get a better exposure. Second, why do you remove this SAN? Because it divides the lymph nodes 2A and 2B के बीच में divide करता है. So to clear 2B, you have to to get adequate clearance, you have to remove this SAN. And for SCM is basically for your exposure part. Okay, now coming to the few OSCEs concerned with this thing. Can somebody give it a try? Which procedure is it? Fiber optic laryngoscopy. Yeah, it can be confused, but ये ठीक है. With this image, you can say. But अगर साथ में ये दिया है तो yeah, somebody answer it. Yeah, Dr. Rohini, please tell me what FEES ना? FEES. Now I request somebody that please give me full form also of this thing. Fiber of
Functional endoscopy evaluation of swelling.
Little bit different. Fiber optic
and the evaluation of swallowing.
Evaluation of swallowing.
Please remember this word. Very confusing. Why is it confusing? I'll just tell you. There's something called as ठीक है. Now who will give me the answer? फिर से ट्राई करो. अभी फ्लेक्सिबल है यहाँ पे. ठीक है. This is flexible.
Sensory test.
Yeah.
Sensory
Yeah, Dr. Apurv. ठीक है. So this is flexible endoscopic evaluation of swallowing with sensory testing. This F is for flexible with sensory testing. ठीक है. तो ये इसका एक supposedly type of recent advance. One thing is, remember it as an acronym. 1 mark it will come. Second, they might ask you to identify. So 1 mark extra will be here. Data जो है इसका, I've shared with you a small PDF. Just go through them, and these are the small comparisons over here. Just see. ठीक है. So they can ask you this thing also. What is MBSS? And this is your fees you already saw. So what are the advantages of each and above? We'll discuss over here. I'll share. When I saw this MBSS for the first time, now I read it MBBS. It's very new on me that I read it MBBS. I thought, why they're comparing MBBS with fees? So the same thing can cause a confusion in exam. We all know what is barium swallow. Okay? But a person who has not specifically not read that MBSS is modified barium swallow study, तो वहाँ पे एक नंबर गड़बड़ हो जाएगा, है ना? We are reading it for 1 mark. So that's why it's important to us. Please remember the full form, advantage and disadvantage of both. Okay. Second, MBS, this we have done. Third is your VFS, basically same thing of visualization of functional video fluoroscopic study over here. So this is the comparison with the VFS. And third will be ये वाला. Okay, this I have shared with you. That comparison of fees versus your barium swallow study. PDF I have sent you in group. Just go through that. Okay. Again, coming to the same thing, it has been repeated. Please go through these muscles of tongue, extrinsic, intrinsic, both of them with nerve supply. And okay, so these are the question that how will you define like imaging which you will do. So CMRI basically local invasion you have to comment, depth of invasion you can comment, and perineural invasion you can comment. These are the specific points. Okay, why are you doing CMRI? These are the things which will give us like an extra edge over it. One, differences between the tumor thickness and DOI. Please go through it. Then, okay, and one more thing with MRI, that it helps us to plan the approach, whether you go for a oral surgery, whether you go for a pull-through surgery. Okay. Second thing, MRI helps us to plan for reconstruction too. Reconstruction mein, I like last time we told that mandible involvement tells us everything about how will you go about it. So for recon, 2-3 things you have to remember. One thing is primary closure. If this is the size, then radial artery, anterolateral thigh, and fibular flap. These are generally preferred if the patient has undergone hemiglossectomy. Types of glossectomy itself is a question. I'll again share a video. I think I had shared it once. I'll share it again. And glossectomy types is important. Team, and if the patient has gone complete total glossectomy, so one option will be PMMC. Okay, so it again depends upon center to center what type of surgery are being performed in your center. Depending upon that, you can answer. This is a rough guideline to that. Okay. Now they will ask you when do you do tracheostomy in such a patient? When the involvement of genoglossus is there. Okay, or when extensive resection you do. Second question, what are the indications for EUA? Full form of EUA is examination under anesthesia. Okay? So these are the points that when the patient is not cooperative, for 3D imaging, like you have to think. And third thing is if we cannot get around the tumor. Okay? This is like these questions I have taken from your TMH Viva on CA oral cavity. I'll share the entire YouTube link with you guys. If you want, you can go through it. It's around 1.5 hours video. Around 2 to 3 videos are there. So these are the questions which were asked by the examiners to the super specialty candidates. So nothing else will come to you because we are just specialty candidates. Abhi ENT kar rahe hum log. Super specialty nahi ja rahe. So your level of question will not be ahead of these things. Okay. So over here, one question. What is the safety muscle of the tongue? Dr. Irfan, genoglossus. Good. And over here only, like one task for you, you have to read about its origin and insertion. Okay? It's a fan-shaped muscle basically. It's a fan-shaped muscle, a big muscle, and called a safety muscle because this is like tends to cause like closure of your airway. Okay, over here, why I have included these 4-5 images? These are from your Kenhab anatomy. इसमें से you have to just see about this marked muscles. Okay, go through these things at your own sweet time. ये वाला is not important. इस तरीके वाले जिसमें marked है ना, they have marked specific muscles. Like here they have marked genoglossus. This can be provided to you as a section A, B, C, D. Identify this muscle. What is X? So what is the other name of the muscle, blah blah blah, what is the nerve supply of this muscle. They can ask you in these format. Like suppose this is xenoglossus again, this is hyoglossus. Let's just recommend it. This is palatoglossus. Like again, they can answer. You see, if you can observe it, na, like this is another different type of muscle. All other muscles are like. It looks like different from the other muscles. This is palatoglossus. So this can very easily be like very good potential of the question that this is something different also. Why is it different? That nerve supply is different. It looks different. So they can give it to you. Identify A, B, C, D. What is the nerve supply of D? So it's a potential question. 3 and same goes for this thing. And this is again your styloglossus. अच्छा अभी बचा हुआ question क्या रह गया आपका? Two things are remaining. One thing is just please remember your feast, FEESST. This thing generally what happens is this is done in 2 phases. The first thing is the test जो होता है, the test it will welcome Dr. Raj. ठीक है, this test will assess the sensation in the larynx. Why? In order to elicit airway protective reflex, whether this reflex is working or not. You remember na main function of larynx. Function of larynx क्या होता है? First function of larynx, what will speak?
Protection.
Okay. So phonation उसके बाद में आएगा. Phonation will come later. The first thing is protection of your airway. So this is the first phase, and if this is okay, then we give food to the patient, जिसमें some food color is mixed, so that we can see that where this thing is going over there or not. So we saw feast, we saw feast 2, and ये हो गया, इसमें से कुछ trending है नहीं बचा, ठीक है. अच्छा, and over here one last thing, what will be the DDs of tongue mass? So whenever you are attempting such a question, always divide it into some parts. ठीक है, one will be your malignancy. देखो यहाँ पे congenital is very rare, है ना? So malignancy में it can be squamous cell CA, it can be some salivary gland tumor, leiomyosarcoma,
rhabdomyosarcoma.
ठीक है, you can just keep on adding to it. ठीक है, so if you keep on like एक बार इसको divide कर लिया, so definitely you can keep on adding extra and extra. Benign में you can add lipoma, ranula, papilloma, blah blah. Then infectious में one is TB, scarlet fever थोड़ा याद रखना है. Just Google 2-3 images of scarlet fever. Okay. And third thing will be syphilis. चौथा idiopathic. इसमें hairy tongue. ठीक है, ग्लोसाइटिस हो सकता है. अच्छा, बस these are the 4. Syphilis. Yesterday we saw one condition related to congenital syphilis. Anybody remembers it?
Some
Mulberry molar. ठीक है, mulberry molars. So this was it. Keep on revising. I'll again tell you, keep saying this thing. 2 months have passed for your theory exam. Now the exam results will be out probably in the next 10 days. Now, normally they take 2 months plus minus 10-15 days के आसपास DNB takes it. They have like DNB and NB was busy in NEET PG settings and all. So definitely we are pushed down the priority line. So probably our results will be out in this week by say 24-25 or the coming week. And after the results are out, we'll have around 3 to 4 weeks extra for acing up the preparation. Okay. So second class now will include 2 more things. Daily we'll be discussing one HPE image. Around 3-4 we have discussed. One HPE image we'll be discussing daily, and one incision we'll add along. So in another 1 week, we'll be covering around whatever incisions are there in your head and neck. apart from head and neck, the ear incisions that we all know, nose incision, 3-4 incisions are there. We know that thing. Main thing is about your head and neck thing. Okay, so we'll discuss this thing. After completion of these two things, we will introduce 0-1 surgery daily. मतलब daily discussion, what discussion we are having, we'll discuss one thing. Like suppose example total laryngectomy, है ना? So what are the important points of total laryngectomy? 1, 2, 3, 4, 5. What are the images concerned with this thing? 5. And what questions can be asked from this thing? So simple one PDF concerned with this thing. One day we'll be discussing say superficial parotidectomy, or one day we'll discuss about some other surgery. So more around 15 surgeries are there for this thing. And remaining thing में 2-3 things are remaining about after this thing. One big thing is thyroid. After we complete this thyroid wala thing, we will be discussing 2, 3, 4 things. One will be biostats, one osteology, and one will be your revision section जिसमें हम लोग सारा instrument revise करेंगे and scientist revise करेंगे and सारे syndrome revise करेंगे. ठीक है? You all have got that PDF of instruments. Somebody doesn't have it, drop me a message. I'll send it again. So, but like these three things now, this is what I like realized. These cannot be done in one day, है ना? So it will be very stupid on my part that I make a presentation, already add some pictures, and this instrument is this is this. That will be a like worthless effort from my point. The day I thought कि I'll start this thing. This was way back 2 years ago. And it was like कि मैं कभी PowerPoint presentation से नहीं बनता है काम. Whenever I saw this PPT, whether it was UG or whether it was PG days, it all went over the head. So these three things, instrument, scientist and syndromes, keep on revising daily. अपना आप उसको बांट लीजिए. Around 15 syndromes are there, 15 scientists are there, and instruments around 20 to 30 will be there. So daily one or two you have to keep on revising, and then that will be like a fruitful discussion. We will keep on changing the images and we'll be getting answer when everybody will speak. So it will be a like more of an interesting class. If I will only speak, so it will be a boring class. कुछ लोग सो जाएंगे, थोड़ी देर मैं भी सो जाऊंगा, है ना? And this will be the one thing. After completion of thyroid, we'll do all those things. And इसके अलावा any topics which you want specifically, if like people have some problem with some sections. So if you have some issues with some sections, drop me a message. We still have plenty amount of time, and we'll discuss those things again and again. And again, I'll request everybody with folded hands. Seoms Commerce. This is our bread and butter. ठीक है? This will decide whether you will be on this side or you will go on the other side. Okay? So keep every day. नहीं अगर ये daily नहीं पढ़ सकते तो alternate day keep half an hour for Seoms Commerce. A to Z, all nitty-gritty, all recent advances, everything, right from your embryology, right from your anatomy, physiology, how this hearing blah blah takes place, what are the theories of hearing, scientists associated with all these things, surgeries, recent advances, this A to Z, इसमें कुछ नहीं बचना चाहिए, ठीक है? From whatever data you get, wherever you get, keep on accumulating, keep on digesting, keep on assimilating. Baki things will continue, we'll cover it daily. We'll increase the frequency of OSCEs also. We'll increase the number of pictorial. अभी तक हम लोग theory वाले discuss कर रहे थे OSCEs. अभी start pictorial OSCEs, like जिसको spotters बोलते हैं. We'll discuss it daily, around 20-25 daily. And again, I request if anybody of you has got any. वेलकम डॉक्टर सुनील. ठीक है. सो किसी का कुछ पॉइंट रहता है ना, इफ यू हैव एनी पॉइंट तो ड्रॉप मी अ मैसेज एंड गिव मी अ days or 2 time for the strip line, है ना? I'm stuck most of the times with the hospital work allotted, and these all things are like I enjoy making these presentations and discussing with you all. I go into my nostalgia of my residency days, so that's my way of escaping from my daily routines. Okay, so give me like whatever problems you are having, just drop me a message कि कहीं पे आपको confusion लग रहा है या you want some extra things on that, we can just add on, keep on adding. And number two, people who are in first year and second year, please make your PDF in a single format, as Dr. Shivam had shared multiple times in the group. इस तरीके से बना करके रखना है, preferably a soft copy. If you want to have a hard copy, that's fair enough, but that will be an extra work. In soft copy, nothing. You have to cut, copy, paste, and your one full PDF is completed of GNA. Whenever you are, like, example, you want to revise GNA, तुमको पता है मोबाइल में GNA search करोगे, that folder will come and you will definitely in 5 minutes whole GNA right A to Z खड़ाखट हो जाएगा आपका. So try revising in this way, and this I'll request instruments, scientists, and syndromes. Okay, daily 1 or 2, whatever if you want to revise everything daily, fair enough, but 1 or 2 daily you have to revise along with the concerned questions that we have discussed accordingly. This will be the most boring part, I'll say, biostats, because everybody has its plus or minus. For myself, HPE and biostat are something which was like, I always had to ratify it. So I'll be discussing all the questions which, one thing I was remaining with it, audiology. I was thinking एक चीज मिस हो रहा है, ठीक है? तो ऑडियोलॉजी के सेक्शंस पे I will be including all the images, not all exactly, but all the named graphs and images which are given in your Anirban Viswas, one, and second, what are the already audiology OSCEs which have been asked. So मोटा मिला के 25 to 30 OSCEs will be there in audiology, है ना? So this will continue. Same will start with osteology and biostats. Chalo, already I've taken too much of your time. Go guys, have dinner, take rest, and again, drop me a message in case of any problem which you are facing. Okay? Chalo, see you guys. Bye, good night.